Good afternoon. Welcome to my presentation on metastatic renal cell carcinoma to the pancreas, ileum, and liver. This is a case report emphasizing that aggressive surgical treatment can lead to improved survival in these patients. So renal cell carcinoma is the third leading cause of urological malignancies after the prostate and bladder. The most common sites of METs for this disease include the lung, bone, liver, and brain. More rare sites include the small bowel, the pancreas, the spleen, the gallbladder, and the ampulla. Although the 5-year survival rates that were initially reported back in 1969 haven't changed much, they range anywhere from about 66% for stage 1 to 11% for stage 4. Have not really changed since then. We present here a case of metastatic renal cell carcinoma to first the pancreas, followed by the mesentery slash ileum, and finally to the liver. So our patient initially presented in 2012 to an outside hospital where she presented with right-sided colic. She was noted to have a large mass on the right upper pole of her kidney and some gallstones, for which she underwent a right nephrectomy and cholecystectomy at that time. Pathology came back, renal cell carcinoma, clear cell type with clear margins. She was then transferred to us in 2017 after two small lesions were found in the tail of her pancreas, for which she underwent a lap hand assisted distal pancreatectomy and a splenectomy due to the proximity of the mass to the splenic artery. Again, her pathology came back as metastatic renal cell carcinoma to the pancreas. During her postoperative period and up to 3 months later, the patient continued to experience low-grade fevers. She was then rescanned and found to have a 3.8 by 2.4 centimeter mesenteric mass in the right upper pelvis that abut the small bowel. On looking back, it was actually present in 2014 on a previous scan, but was smaller in size and therefore wasn't picked up. So working differentials at this time included GIST versus mesenteric adenopathy fixated to the small bowel versus carcinoid, and less likely metastatic renal cell carcinoma given the rarity. She underwent a PET scan that did not illuminate and elected for observation and surveillance at this time. In 2018, she developed anemia, and concern was that this was secondary to that small bowel mass. At that time, she elected to undergo an EGD colonoscopy, followed by laparoscopic resection of the mesenteric mass in the adjacent small bowel. Pathology returned metastatic renal cell carcinoma, again clear cell type. She was started on sunitinib per her oncologists after the stains and the pathology. In 2020, she represented after surveillance again with 3 liver masses on follow-up imaging, for which she underwent robotic lysis of adhesion with intraoperative ultrasound, where the 3 lesions were identified and 2 of them were resected. The third lesion, however, lacked malignant appearance, and an intraoperative radiology consult was placed, and decision was made to leave that mass alone due to the nature of the disease and potential need for future liver resection. She had a relatively uneventful course and was discharged home on post-op day 3. So my patient is still living. She's still currently undergoing active surveillance. She's 8 years after her initial diagnosis and 3 years out from the discovery of her metastatic disease. So the lung and the bone are the most common sites of metastasis for renal cell. Pancreatic METs account for only 5% of all pancreatic malignancies, but can also be a common site for renal cell carcinoma and resectable in about 80% of cases. So surgical intervention of a solitary pancreatic mass or a solitary small bowel lesion should be attempted in those patients who are candidates, as complete resection metastectomy confers a fairly decent 5-year survival rate of anywhere from about 30 to 50% respectively. One thing I did want to point out is in the literature, the absence of complete metastectomy was associated with a significantly increased risk of death from renal cell carcinoma, which is something important to note. Our case emphasizes the necessity of close follow-up, repeat imaging, and that despite the rarity of metastasis in certain locations, they must always remain in the forefront of the differential in these patients with a known history of renal cell carcinoma. Thank you for listening. Have a great day.